Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the podcast. This is Aebhric O'Kelly. This week, we are with Dr. John Quinn, who is on our teaching faculty. He started out as a paramedic, and now he has his MD and his PhD. John, welcome back to the podcast.
Great to be back. Thank you for the opportunity.
So tell us a bit about yourself and what's keeping you busy.
Yes. So I've been fortunate enough to be able to be working between the United Kingdom and volunteering in Ukraine and occasionally working elsewhere throughout the United Kingdom NHS sort of trusts everywhere. But I've been fortunate enough to be able to do some volunteering training missions throughout Ukraine over the last few months. And I've also been able to try to push things forward on the research side for damage control resuscitation and damage control procedures, really for the last 2 years or so.
And that's something you've done with the college and Dr. Tom Mallinson. You've done a DCP course in Ukraine. So how about we start at the very beginning? John, tell us, what is damage control procedures? What precisely is DCP?
Sure. Yeah. So it was great to be able to engage with Dr. Tom for the damage control resuscitation and the damage control procedures workshop. Basically, the long and short of it is this: in the remote medicine and really the far forward and austere medicine paradigm, we need access to certain things. So Tactical Combat Casualty Care gives us excellent access to point of injury care, and it really sets us up for success for any sort of prolonged casualty care or prolonged field care environment, which is great. However, really what has to happen at some point is that patient may require damage control resuscitation, which is a really fancy way of saying they're going to have access to blood as well as all of the other aspects around it. However, that's only part of the story. The other part of the story is that we need to stop the bleeding, actually, definitively. So not just a tourniquet and not just sort of pressure and not just these adjuncts, which are very helpful and excellent for the patient, but really damage control procedures takes it to the next level. And at the way far end of that damage control resuscitation and also damage control surgery paradigm, that sort of that trajectory for that patient, that damage control surgery is really only available for surgeons. So there's these great courses out there. There's the Asset Plus, the COT, the COTS, and the COTS Plus course, as well as the HES course, which is a humanitarian focus. All of these abbreviated courses for damage control surgery are brilliant for surgeons. And in some instances, they're brilliant also for anesthesiologists or anesthetists. However, there's a gap. There's this gap between damage control resuscitation, the stuff that a lot of paramedics and a lot of far forward doctors will be doing, and what those surgeons will be doing. And the gap is kind of twofold. One is in a paradigm, an academic paradigm of what you're allowed to do, so a governance thing, but it's also geographic, where the surgeon may actually be sitting and waiting for a patient to come, and where you may be far forward with a patient, there's actually that gap. And we say, how can we close that gap? So the concept of damage control procedures, which has really been, it's kicked off significantly, not only with the College of Remote and Offshore Medicine, but also with the Disaster Health Institute, and kind of bringing together loads of partners, different universities, different specialists, different subject matter experts, and saying, listen, we need to get our heads around this, and we need to push this forward. So the concept of damage control procedures is really trying to address that gap of saying we may have a delayed medical evacuation environment. We may not have access to surgeons, even though a lot of surgeons have a lot of guts and they're willing to push far forward, and they're willing to do a whole lot of stuff far forward, but still, even so, you may have that geographic gap and that tyranny of distance, and you may also have that gap of saying, actually, we need to do something. We don't have access to a surgeon, and we need to be able to do some of these damage control procedures so that we can help reduce preventable morbidity and mortality. So in a nutshell, that's sort of what the concept of damage control procedures is and does.
So this is about surgical skills for a nurse, a paramedic, or even a combat medic corpsman, and having them do doctor level, no, not even doctor level stuff, surgeon level skills.
Yes, absolutely. And it's absolutely. And it's really out of necessity. So yes, you're right. Nurses, combat medic, corpsmen, combat medics, paramedics, EMTs, doctors, and other healthcare professionals that really want to upskill. The concept is to be able to give them training so that they can save a life when it's required. Now, having said all of that, there's also governance consideration. So a lot of countries will say, no way, Jose, this is impossible. There's no way we're going to allow this to happen. There's other governance issues for paramedics and for doctors. For example, an emergency medicine doctor or a nurse or a paramedic saying, actually, we're not allowed to do that. So there's a whole lot of governance issues to overcome. However, we really need to just push far forward, do what needs to get done for the patient in this paradigm, this concept of damage control procedures under the auspices of clinical governance saying, yes, you are allowed to do this. But first and foremost comes the training, comes the capability of being able to recognize the patients that require advanced and escalation level of care, and then being able to have the skills to actually competently execute those interventions. So it's quite a complex web of considerations. But yes, you're right. It's not just for surgeons anymore. In limited capacity, it's also the idea of being able to give these skills and give them into the hands of competent paramedics, nurses, other doctors, other healthcare professionals, as you said, combat medic corpsmen, combat medics, EMTs, etc.
So, John, there's a lot of publications on damage control surgery for non-surgeons on PubMed, but they're referring to giving surgical skills to non-surgeons, meaning other doctors, and not to non-doctors. So how angry, how cross will the surgeons be when they hear about this program?
Yeah, I think it's really important to put it in a framework. I think I won't speak for surgeons. I know that surgeons wake up every morning and they wake up at 3 o'clock in the morning when they're on call to go and save lives. That's why they are willing to do their residency for several years and decades, in fact, so that they can save lives. And as I said, they have guts. They're willing. A lot of surgeons, especially in Ukraine, are willing to push far forward, and they're willing to do surgery in basements very close to the line of contact. However, the line is huge, and sometimes the resource that surgeons have cannot spread across the line to all the areas that it's needed. So it is possible that the concept of damage control procedures will really rattle a lot of cages inside the surgical community. However, I think it's an opportunity to be an adjunct, a surgical extender. You can extend some of these aspects under the auspices, under the direct care and supervision by a surgeon saying, hey, listen, I've trained you on how to do this. I feel comfortable with your skill on how to do this. You may even have the ability to discuss the case over Starlink or other protected internet via telemedicine, maybe even something as simple as a WhatsApp or a Signal video call, or sending different photos back and forth, or just having messaging back and forth over secure communication saying, okay, based on all the information you said, we've got 3 days for an evacuation. This patient is likely to perish unless we try some of these interventions. And I feel comfortable and confident with your approach. So let's continue that. So really, an extension of that surgical expertise. Of course, that won't happen in all environments, and it's yet to be consistently tested. But that's really, I think, the best pairing opportunity for surgical extension, and really having close surgical oversight, saying, listen, we can do this. We have the skills, we have the training, we have the equipment, but we need the go ahead, essentially. And I think surgeons need to assess that, and they need to give their own feedback as well, and say whether or not they're happy with it, in across all NATO and NATO partner nations. And just to go back to some of the partners that started with this within the College of Remote and Offshore Medicine, we have surgeons that have looked at this curriculum. They're still reviewing a lot of this curriculum and the concepts with really a whole lot of thumbs up. We also have the Disaster Health Institute, a lot of surgical expertise and subject matter experts also reviewing and supporting the curriculum development, in fact. There's other partners such as Persepolis Medical University that have given massive support, and really some of the early considerations of the curriculum really came out of discussions with surgical expertise, trauma surgical expertise, not only from Europe, but also from their experience in North Africa and elsewhere in Asia. So there's a lot of surgical roots and surgical DNA inside this curriculum and inside this concept. And it just needs to be explored. It needs to be considered, and it really needs to be pushed forward.
John, you've designed this and you've run this in Ukraine. Walk us through how the DCP program is. What does it look like? How long is it? What skills are you teaching? What surgical skills are you giving to the medic on the ground?
Sure, sure. Well, and just to go back a little bit, we have done a damage control procedures workshop, so a limited workshop, really focusing on gathering a whole lot of information, specifically related to damage control procedures. We've also done a lot of these isolated skills, and College of Modern Medicine and the Disaster Health Institute are not the only groups that have been trying to explore some of this. There's also been organically inside Ukraine, out of just sheer necessity, really trying to better understand some of these skills, not on a mannequin, not on not in a very quiet training environment, but in the field, in far forward environments, with cadavers, etc. And a lot of their qualitative and anecdotal feedback is also fed into these concepts and systems. So just to go in kind of in three phases, there's basically three phases, and in some instances we refer to them as tiers. In some instances we refer to them as echelons of care. But the first one is kind of a review, and it's really a review of the combat medic corpsman. So the idea is that if you are not a good, competent combat medic corpsman within procedures, but you have the interest and you want to upskill yourself, the idea tier one is really a combat medic corpsman skill course, a slightly expanded skill course. So there's a surgical airway. There's the chest drain, so a finger thoracostomy and a tube thoracostomy. There's intraosseous, and there's also a very specific look at how to use tourniquets. And I know it sounds kind of basic, kind of rudimentary for a lot of folks out there saying, "Oh, come on, tourniquets. We've been doing that from since day one." But being able to really approach, hey, how do we really convert that tourniquet? How can we downgrade that tourniquet? How can we replace that tourniquet? And how can we do it safely in a far forward environment where we don't entirely take something off, but we just sort of we try to minimize the amount of morbidity associated with that tourniquet, but also maximize the medical outcome. So we look at that as well within tier one, and then also the idea about having access to really assessing a traumatic amputation. And then in tier two, we have a really expands quite a bit, and we have a limited laparotomy. And we have so that's really a laparotomy where you open up the abdomen, you pack 4 quadrants of the abdomen, you really pack that liver in the event that it's bleeding, obviously with really its indication, and then you have a damage closure, as well as the concept of the lower limb, external fixation of the lower limb. And the reason it's the lower limb only is that, you can really get some excellent immobilization of the upper limb, even with partial traumatic amputation, and being able to secure that upper limb, especially for, working age men and women, you really want to maximize the outcome. So whether it comes to a surgical specialty for the upper limb, the hand, the wrist, the forearm, and the upper limb as a whole, you really want to do that well. And so in the lower limb, it's a little bit easier to train, and it's a little bit easier to be able to get a lot of the tips of the trade and the tricks of the trade to be able to do the lower limb well with external fixation, which is when you actually drill screws into the bone, and then you have an external rod to give support for lower limb, either partial amputation or significant trauma. And so that's kind of the focus of tier two. We also kind of expand a little bit and go into a little bit more detail on some of the aspects of surgical amputation, and then also expanding a little bit more about burns, escherotomy, and fasciotomy, and really, kind of going into a deep dive into advanced burn care. So that's more or less. And some of these are interchangeable. So as we're kind of walking through different tiers and we deal with different groups, they say, well, actually, hold on, we want it as a menu. We want that item from tier one. We want that put in tier two. We want that item from tier one and put it in tier three, etc. Tier three is a bit more extreme, and we look at the use of burr holes. We also look at the use of advanced technologies and the use of partial retrograde endovascular balloon occlusion of the aorta, or partial REBOA. which is something that is very controversial. And controversial with surgeons, controversial with pre-hospital providers, controversial with hospital providers. And it's when you use a central line in the artery, and you actually put a catheter with a balloon all the way up to zone 1 inside the chest for a traumatic and obtunded patient who is really doing poorly, and then you can partially occlude the aorta and really better understand what is going on, what you need to do to stop the bleeding. Hopefully, you can get some blood on board, as well as do a whole lot of intervention. And so that's sort of the walkthrough. There's also an advanced technologies, essentially the concept of what will become phase 3 likely in the next few years, but right now it's more or less a phase 4, which is really quite slick stuff. So that's looking at brainwave activity. It's looking at doing hemofiltration, which there's a lot of great evidence in the literature right now, especially within trauma. And to be honest, Ukraine is leading the way. They have this excellence in medical care for the modern battlefield, and they're doing quite a bit with hemofiltration. So you have a patient that may have waited 12 or 18 hours with significant trauma, and they may have just absolute massive muscle injury, internal organ injury. They're really dealing with a lot of metabolic and respiratory acidosis and other really challenging issues for the kidneys. And so the idea is that if you have a very cheap, very easy, relatively easy kit to use for hemofiltration, you can actually filtrate out the blood and filtrate out a lot of those metabolic components that may be actually causing harm. And so if you can filter those out well and still put the blood back and perhaps even transfuse more blood, you'll be able to actually have much better outcomes in the long run. Now, the data is still forthcoming. It's not readily available. It's not super cheap just yet. And it's not terribly easy to use just yet. However, as those technologies are coming online, we're dealing with a lot of those innovative technology providers to be able to better understand, hey, how can we plug this into to the system? Also, with the idea of burr holes, so for intracranial pressure, there's a few systems that actually are a little bit easier for the purposes of ICP measuring, as well as being able to offload some of that pressure. So there's a whole lot of moving pieces. It's obviously not just for a specialist in emergency medicine alone. This is transdisciplinary, requires neurosurgeon input, requires vascular surgical input, traumatic surgical input, and several other specialties to be able to really link it in at just-in-time medicine of saying, listen, this is exactly what's needed. We have a highly contested environment. We need to be able to upskill a lot of these providers. We need to be able to put these tools into their hands. It can't be terribly expensive. It can't be huge and burdensome and heavy. And we need to be able to go into a building of opportunity or a vehicle of opportunity, and be able to execute a lot of these very specific interventions exactly when they're needed, to be able to reduce preventable morbidity and mortality. And I should also say, really as like an overarching concept, because I know a lot of people may be saying, this sounds absolutely crazy. We do have a few seminal papers that have already commented on this a little bit, and quite a few conference presentations kind of unfolding it. And the event that we did in November in Kyiv really kind of set the tone for a lot of the feedback and really helping us polish off the concept of the curriculum for damage control procedures. But we have a lot of paperwork, a lot of papers coming out academically trying to unpack this and put this within a framework, and really make it a little bit easier to describe and for others to understand, hey, this is kind of where our thought process is. This is where we were going with this, and this is what the curriculum is looking like. And so that's really the whole concept of damage control procedures, more or less in a nutshell.
Is there anything in motion to have a telemedicine requirement for like virtual oversight with the surgeon, or having just a WhatsApp video of you're doing a burr hole? Are they going to be discussing this with a surgeon before they do it?
The idea is that you should be able to work autonomous and offline. So the idea is that you may not have access to telemedicine. You may not have access to clinical oversight. You may not have access to medical control or medical direction. And so if you have excellent skills, if you have excellent indications for execution, and you have clear triggers, it'll be a lot easier for the provider to be able to say, listen, I need to pull the trigger on this. We need to do this. Now, having said that, that's a very challenging environment to put a paramedic or someone who does not do these types of procedures to scale or to the volume that to give them confidence. And so having access to that telemedicine, online or offline medical control will be significantly helpful. Obviously, online medical control and telemedicine support is really the standard that everyone is pushing for and everyone wants. There are a lot of units that are far forward that have access to telemedicine. They have access to networks, and they do have access to medical support where you can give a picture, you can send vital signs, you can send mechanism of injury, time since injury, and interventions done thus far, as well as, hey, we're totally delayed. We are literally behind enemy lines, and we do not have access likely for the next 2, 3, possibly 5 days. And it'll make telemedicine decision making a lot easier to have all of that information. You may only get part of that information. It may not be live and online. You may have to send a packet of data, and that data may take several minutes or even hours for it to actually reach the surgeon. So obviously, having contingencies with that offline medical control will be fundamental. There's also the potential of just the sheer volume of patients being dealt with. You may not have access to a surgeon that is actually available to be able to sit and listen and comprehend and digest the clinical information being offered in the event of a large-scale combat operation that involves, all elements of power. So it is I think it's very important to have both that online telemedicine component saying, hey, listen, I really want to discuss this case before I start doing something. But at the same time, appreciating and understanding you have to have that offline telemedicine and medical control, medical direction. And this is where governance really takes a role. You have to have surgeons willing to say, listen, I'm not willing to have this take place on my watch, so to speak, but I am willing to have this and this and this take place as long as I oversee and approve of the curriculum and oversee the training, and I approve different providers to be able to do this. If you think back to in pre-hospital days in North America, there were several instances where in order to be able to provide intubation in the pre-hospital space, you had to undergo several numbers of intubations, not only in surgery and surgical theaters, but you also had to do them in the pre-hospital space. Then you get signed off, and the medical director would say, okay, you've done X number of intubations, not only in the hospital, but also in the pre-hospital space. Under some level of supervision, you now can do this skill autonomously. And so there's it's a much larger spectrum when you deal with damage control procedures. If you think about a limited laparotomy, holy cow, that's a very involved intervention. If you think about any of the interventions mentioned, including those from Tier 1, which are really an expansion of sort of combat medic foreman skills, those are intense intervention. And if you don't manage those properly, if you don't address those properly, if you do not intervene at the right time, you can definitely cause harm. All of these interventions, 100% can cause harm. 100% can lead to an absolute unfortunate morbidity and mortality. 100% that can happen. As with anything in medicine, everything that we do can definitely help, and it can also cause harm. So being able to give these skills is going to be able to hopefully reduce preventable morbidity mortality, but we have to do it smartly, wisely. It can't be done 9 years from now. I think 9 years from now will be too long. I think we have to be able to do a lot of these things now. I think we have to crawl, walk, run. I think we started to crawl. I think we're starting to walk, and at some point, probably in Q1 and Q2 2027, I think we're going to be running. And we really need to be able to get these skills into the hands of these providers. And additionally, with this is not just procedures. We have to also think this doesn't replace anything. This only adds. So we have to also think about the damage control resuscitation clinical practice guideline from the DHA, from deployed medicine. And there's actually a few. There's one for prolonged field care. There's the overarching damage control resuscitation document. Those are the same skills and concepts that have to be followed, right? We still have to get blood and blood products on board as soon as possible. We still have to have appropriate and responsible resuscitation. We still have to provide all of these other adjuncts with resuscitation, such as TXA and calcium. And we have to be able to provide these basic interventions as all, as you and I both know from all of our training. You'll never get to that those cool, sexy, advanced skills without excellence in the basic life support. So we still have to remember that this is not a replacement. We're not saying, okay, well, this is damage control procedures. Now we don't have to worry about all this other stuff. No, not at all. The basic life support still remains the mainstay before we jump into these really cool advanced procedures. And this is, something that I think all of us appreciate in the teaching community, and in the execution operational environment, basic skills are really what saves lives. And all the advanced stuff is brilliant. It's excellent. It's high speed, and we want to do it. We want to do it well. But really, we'll never get there without having just absolute excellence in our own operational environment of the basic skills as well.
You mentioned in the history of paramedics, I remember watching the TV show Emergency back in 1974 about the first paramedics, and they needed to call permission. They had to get medical oversight for giving an IV or even oxygen. And then, small steps we built from that. So we had to start from somewhere. Are you seeing this being something similar to what we had to start as paramedics until now we're up to doing a lot of stuff on our own?
Absolutely, and it's an excellent reference point. My paramedic instructor, instructor Patrick, he would always talk about Rampart, 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 the name of the hospital to call for medical direction when you have access to one of these fancy radio phones, etc. Yes, I do see this is the way that things are going. I'd point out two skills that come to mind anecdotally from my experience in Ukraine: intraosseous and chest tubes. Intraosseous access was just a challenge, as was needle decompression, a massive challenge. And as things expanded, as things grew forward, it became a little bit cheaper, so cheaper to train on, cheaper to get your hands on, cheaper to use. Yes, there were inappropriate intraosseous placed. Yes, I can verify that. Yes, that took place. However, as you train it to scale, especially for patients that are appropriate to receive intraosseous, especially for damage control, resuscitation, and transfusion medicine, it expanded massively. And it wasn't necessarily legal, and you did have to get permission. And even with permission, people would still kind of bicker over the governance aspect. And now you see a large expansion of that component, of that intervention, of that modality to help patients massively across the line inside Ukraine. The same thing for finger thoracostomy and tube thoracostomy. I think the it's a little bit more limited, certainly. However, you have definitely seen an expansion of the level of training of chest tubes. I was doing chest tube training in 2014 with about 6,000 to 8,000 people in 2014 to 2015. By 20 and other things taking place between them, obviously, by 2022, we were kind of back to baseline where not a lot of people had access. It was not an intervention that was taking place in the pre-hospital space in Eastern Ukraine. And very rapidly, not only surgeons, because technically within the governance structure, surgeons are supposed to be doing this. And rapidly, you had any doctor that was receiving patients by 2023 that had training with finger thoracostomy and tube thoracostomy of patients that required that. You'd have a much larger access. Again, it's qualitative. I'm not going to tell you the number of role ones or role twos across the line that had access to this, but it was larger than what it was in 2022. It was larger than what it was in 2014 and 2015. So that slow expansion of being able to provide best practices for really life-saving intervention. So we know that attention pneumothorax or pneumohemothorax will kill a patient. And being able to get that finger thoracostomy as soon as possible, being able to get that tube thoracostomy as soon as possible will be life-saving. So that has expanded. I don't have a number for you, but it has expanded, and the scope has expanded. And that's just one small example of what are certainly advanced skills, but in the grand scheme of damage control surgical interventions, those are only a few. And then it kind of goes up from there, right? So I would say that those are some basic examples of where you could actually see that going, in reference to being able to have medical control, reaching back, hey, I've done the training, can I do this now? And after you do that a few times, then the surgeon's saying, yes, you have a standing order. You're allowed to do a finger thoracostomy, or you're allowed to do an intraosseous access, or you're allowed to do a needle decompression in the axilla, no longer an anterior approach. And being able to do that. And for nurses, for combat medics, for EMT equivalents, 68 whiskeys, etc.
So what's next for the DCP pathway? What needs to happen now?
Yeah, so the DCP is exploding. The damage control procedures course, we've already executed a few elements of right now. We're really working hard to get governance online. Doing cadavers in Europe is a challenge. There's obviously a whole lot of technology that exists to do these types of courses, and I think the HES course has an excellent model, and the Asset Plus course normally uses cadavers. There's actually a few that are coming up that are available in Europe. I encourage our surgical colleagues to reach out. Unfortunately, if you're not a surgeon, you cannot do the Asset Plus course. I think really what the idea of the full package and the idea of being able to offer it in its entirety, specifically right now to those who need it most, which is in Ukraine, and being able to provide a full package to a large cohort of trainers, of learners, and being able to have a train-the-trainer system where I just to take a bit of a side detour. Ukraine and Ukrainian military medics are fighting in modern warfare, and they have a lot of learning and a lot of observations and a lot of lessons that a lot of them are being shared with NATO and NATO partners. It's true. However, a lot of them are being lost. They're being missed because there's just the engagement that needs to be increased. We need to increase our engagement and support for our Ukrainian colleagues. We have to be able to kind of shut up and listen to them and listen to what they have to say and listen to their experience and their observations. And instead of necessarily teaching or training them, although obviously medicine is a science and it's a vocation that we do exchange from one person to another. It's a two-way street of exchange. We need to listen, and we need to really hear what their experience is as well. So the damage control procedures will be procedures offered in Ukraine. Obviously, there's going to be two echelons offered in 26, and then we want to do the full package, start to finish, in 2027. And I think it's a great opportunity. This is not just for the special operations, community. This is not just for the far forward, high speed, low drag military medical community. This is really for all of those in the pre-hospital space. So within Ukraine, obviously, there's the disaster response, there's the Ministry of Health, there's the Ministry of Internal Affairs, and of course, the Armed Forces of Ukraine. And we want to be able to offer this to as many people as possible. And I should comment as well. I mean, there's a lot of other softer skills, such as the surgical basic surgical skills. So the idea about what it is like to work in theater and then try to be as sterile as possible in that far forward environment. There's also a few more comments about resuscitation, not only with blood products, and also adjuncts. Unfortunately, there's not enough blood. There's not enough universal donor blood in country to be able to provide for all the patients that we have. There's also not a lot of blood components necessarily. So being able to look at alternatives as well is also part of the curriculum.
John, you mentioned Disaster Health Institute. Tell us about DHI.
Yeah, DHI. So I'm double hat. I've been a faculty for College of Modern Offshore Medicine. It's been an excellent experience. I also helped support the starting of a non-for-profit with the Disaster Health Institute, and they are really a collection of subject matter experts, mostly from the disaster health, epidemiology, far forward operational medicine, and disaster response, North America, Europe, Central Asia. Elements from Africa and South America, and really trying to bring forward the concepts of best practice at a very high level, so a very operational, strategic level, and trying to bring best practices to the places that need it most. There's been a whole lot of engagement and coordination with several different institutions, including the European Union and other response disaster institutions that do a whole lot of stuff operationally. But it's kind of trying to be a bit more focused on the strategic level. There's been a lot of workshops that have been put forward, trying to bring subject matter experts, doing some red teaming and some really challenging exercises in what are we going to do if X happens? So disease X, obviously event X, not just conflict, but also disaster in general, and really trying to bring forward not only subject matter expertise from within the Disaster Health Institute, but also from around, and really bring together and be a collaborative of saying, hey, we need to link up all of these things. We need to let data drive our decision making. And if we don't have that data, we need to run out and get that data. We need to run out and capture that data. And so that's one of the things I think DHI really on the front of it, they look at strategic policy stuff, but a lot of their subject matter experts also engage with operational things as well. So trying to bridge those two things, as you know from working in College of Foreign Officer Medicine, it is challenging when you engage with big decision makers doing a whole lot of stuff at a high strategic level, and then you're dealing with really operational guys and gals that kick in doors and that put tourniquets on. That is being able to communicate and engage with both groups of folks is it's a bit of a skill, it's a bit of a skill set to be able to get the data that's needed and to be able to convert that and analyze that and speak to those that are having the final decisions on a lot of things, hopefully to make everyone's lives better.
Are you going to be speaking about DCP at the SOF CMC conference in Paris?
I think I'm missing the CMC this year, although there may be a late entry. But I really those guys are doing great work. Being when I think I was able to bring forward the concept of taking really advanced skills and pushing them down into uh, echelons closer to point of injury. So this was in the CMC in Germany, and those are just it's a great community of folks. The organizers there they move mountains when they put these things together. And that flip flopping between having it in Germany and having it in Paris, it's an excellent mixture of subject matter expertise. Not only in the special operations medical community, but also across the board in everyone that is preparing for and hopefully preventing the next large conflict. But I mean, we need to be ready for it. And I think they're doing a great job of information sharing, very ad hoc, very practical information sharing so that everyone understands, hey, what do we need to do? What are best practices? What is the data saying we need to do? Most of the data is true. It's coming out of Ukraine for the last 4.5 years, for the last arguably 12 years. It's been coming out of Ukraine, and we need to capture that data, analyze that data, and they're doing a good job of doing that. And there's also a lot of data coming out of the Indo-Pacific theater. There's a lot of events that are coming out of the Middle East. We need to capture that as well, and we really need to be able to put our heads around it so that we can better understand what works in one theater may not work in another. It's absolutely true. What works in one military or in one unit may not be transferable, although elements of it may be. And I think the CMC is a great venue to be able to engage with everyone in a very peer-to-peer manner, and it's a great environment. It's a great group of folks, but I think I may be missing it this year, unfortunately.
So also, you and I are hosting another webinar for the Royal College of Surgeons of Edinburgh at the end of June, and you wanted this as your topic, isn't it?
Yes, that's right. Yes, damage control procedures and really unpacking it in a bit more academic rigor, bringing a little bit more data from some of the events. One event that I should comment on that Dr. Tom and I were able to do is a workshop of trying to unpack and sort of pull information out of the Ukrainian experience to be able to better polish off the curriculum of the DCP, really specifically for Ukraine. So essentially, it was we ended up in late November after doing a damage control resuscitation training, which is absolutely brilliant with our partner Tactical Medicine North, who are just an absolute brilliant provider and service provider for pre-hospital care within the armed forces of Ukraine. But they also do a lot of training, and they really they pack a punch well above their weight class. They do some great stuff, and in that damage control procedure workshop, we used a nominal group technique, which is really a fancy way of saying we let everyone's voices be heard without giving any attribution. So we got a lot of field folks in the room, and we from across the board, and we had Chatham House rules. And we're pulling information out. Well, what's working, what's not working? How do you define role one and role two? And what do you want in role one and role two? And how do you define those skills specifically? And we kind of teased out a lot of information. It was quite combative at times academically. It was extraordinarily challenging. Um, and by the end, we were able to clearly define what they wanted, what they defined as role one, which is actually one of the papers that'll be coming out. They really wanted to classify that as role zero, which was very interesting. It's got a bit of a paradigm shift to the military medical paradigm from NATO and the concept from the Department of Defense, Department of War. the concept of role zero and really what they want to have available there and what they're willing to have available there. These are folks that are functioning under ground rocket fire and under drones in basements, and they scurry from point A to point B in small groups so that their footprint is smaller. I mean, these are really far forward folks. They said, this is what we want to do. This is what we consider to role one to be. This is what we consider role zero to be. This is what we consider role two to be. And this is these are the exact skill sets that we would like at each of those echelons of care. And more importantly, these are the types of medical providers that we described. So we defined the competency and the skill sets of the different types of providers inside Ukraine and where we want them to be at role zero, role one, role two. So it was a mapping, a lexicon mapping exercise. It was a descriptive exercise, but most importantly, it was the Ukrainian voice of what they wanted, what they saw was the need. And then we were able to polish the curriculum so that we could face and we could meet the challenge of those needs at each of those echelons. Now, it won't be perfect, obviously, and I think even since November, the threat level has changed. The number of fiber optic drones, the number of drones that attack medical personnel by the Russian forces, the number of buildings that are attacked with really heavy weapon systems, and the level of gray zone and hybrid warfare that is taking place across Ukraine is extreme, and it's more extreme now than what it was in November. And despite the excellent the positive news that we're hearing coming out of Ukraine about the increased use of land drones, air drones, and really being able to leverage that with the use of AI systems to capture land. I mean, this is all excellent and great and positive. There's still people dying every single day. And there's still significant challenges in dealing with a huge adversary, with a lot of people, a lot of technology, and no qualms about completely obliterating the concept of Geneva Convention. No issue whatsoever about attacking civilian infrastructure, and also no issues whatsoever about going after healthcare facilities, medical evacuation facilities, and vehicles, and doctors specifically, and medics specifically. So, really, still a massive challenge and a massive threat. So when we were back in February and in March doing some training near some borderlands, that was great to get additional data capture, again, qualitative data capture of what we see is going on and what the feedback we're getting back from them. But overwhelmingly, all of them said, yes, we need the DCP. We need access to, at a minimum, tier 1 and tier 2 concepts of the damage control procedures, because we are getting patients we cannot deal with. We do not have the skill set to deal with, and we're getting patients that need far more than what we can do. We can't get them to where they need to be in time. And so that's that challenge. Despite the threat level getting worse, despite the change in the battlefield, still we still have this gap, this damage control procedures gap that we need to address. So hopefully we'll be able to address this gap in late June and July when we go out again and do some additional far forward training, specifically with tier 1 sort of stuff and tier 2 damage control procedures, and also establish a little bit better network for cadaver training and a handful of other logistical things that we need to get online. And so that's really the need. So as creative as it is that we're getting this out there, I still feel like we're late. We're not too late, but I think we're still very late, and we need to get the Ukrainian involvement much more, get their input and their feedback. And anyone listening to this, I would encourage all of you to engage more with Ukrainian colleagues, not just trying to pluck them for information. Obviously, they're very busy. They're dealing with patients on a daily and hourly basis, but more importantly, what we can do for them and how we can support them. And I think that's something that is across the board, whether you're doing disaster health stuff, whether you're doing humanitarian health stuff. We need to be able to provide a lot more support, material as well as personnel, if you are willing to go and volunteer and spend some of your time and expertise in country. So I encourage everyone to to mobilize and provide more support. Absolutely.
For the listener who is interested in learning more about damage control procedures, are you planning on running a DCP workshop at our Medicine and Mediterranean conference at the end of January in Malta?
Yes, absolutely. We were able to get elements of the damage control procedures, really damage control resuscitation in Ukraine, which we had concepts of the DCP. We had some very specific skill sets there, blood warming techniques, partial REBOA, etc. Yes, the answer is yes. If you have interest in damage control procedures, we will be running a detailed damage control procedures workshop with a whole lot of new information, new data sets. And a lot of hands-on stuff to do in January in Malta, 2027. We're very much looking forward to that. It's going to have a completely revamped approach. We're going to have a whole lot of information from the missions in Ukraine, and we're also going to have access to a lot more procedures themselves. And I would definitely encourage anyone that has interest to be able to take a look at that and see what see if you're available. If you're available to come out in late January in Peru, we'd love to have you.
John, my final question for you is this: what advice do you have for the remote medic, the nurse, the doctor who is just starting out in their career in austere medicine?
See as many patients as you can. So I definitely I think it is challenging working in the pre-hospital environment. It's challenging working in austere environments. It's challenging working in this type of environment. And the confidence I get personally is by seeing patients, certainly by doing training. I just completed my ninth or seventh or eighth, maybe my ninth advanced trauma life support training. And instructor training. I still do my advanced burn life support, my advanced cardiac life support, all of these types of training that you do every 2 years, every 4 years. It does help with confidence. It helps builds your confidence. It's expensive. It's difficult. It's challenging to plan it. But when I see patients, I am encouraged and I am reinvigorated. So if you're out there and you're like, I really want to get into this, I want to learn about this more, etc. I think you need to increase your patient volume. And when you do have patients, do your exam and document your exam, do your exam well, cause no harm, first do no harm, and really focus on these basic skills so that they become second nature. One of the opportunities I had in 2004 to 2006 or 7 or so, running a small clinic, multiple small clinics throughout Iraq, patients came in all the time and they wanted tablets for headaches and tablets for this and different things with their big toe, etc. Use it as an opportunity. Use it as an opportunity to do a physical exam, take a clinical history, a detailed clinical history, and really sharpen your clinical skills so that you have confidence. You have confidence to deal with the emergency, and you don't become complacent, and you don't say, "Oh, this is cool. I get to sit in the desk and do this and that." No, get off the desk. Go around, see the area that you're at, look at the public health, think about the epidemiology that you can provide support with. The far forward medic is not just ready for the heart attack, not just ready for the trauma, but it's you're a provider of health. And so being able to really encourage and run out there, do a whole lot of different things, capture a whole lot of information, gather a whole lot of information, try to analyze that and try to speak with mentors and engage with mentors so that you can make the healthcare of the patient in front of you better, but also the environment, the community that you're dealing with, whether it's 4 guys on an oil rig, or whether it's 123 local nationals at a copper mine, and everything in between. Be able to really sit down with your patient, sit down with your community, and capture a lot of information so that you can hopefully make the community better. Not to sound like a broken record, but reduce preventable morbidity and mortality. And really look at what you can do to do that actively and practically.
Dr. John Quinn, it's fantastic to have you on our faculty. You're making a difference in this world, and I think a little beam of light follows you around, hitting you on top of your head as you walk through life. And thank you for all that you do in the community.
Thank you so much for the opportunity. I appreciate it. And that light is probably the police chasing me.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being